Good morning. Today I'm going to discuss the topic osteonecrosis of femoral head. We are going to discuss this in three parts. So, osteonecrosis of femoral head is a major cause for groin or hip pain. It causes progressive collapse of the femoral head with joint destruction. It has an incidence of 3 per lakh population and is commonly seen in the age of 30 to 49 years. Also, it is more prevalent in males compared to females in a ratio 3:1, and it accounts to 10% of total hip arthroplasty surgeries done throughout. So, the risk factors are mainly divided into the direct factors, which can be due to trauma, radiation therapy, malignancy, hematological disorders such as sickle cell disease, hemoglobinopathies, thrombophilia, orthopedic disorders such as SCIFI, developmental dysplasia of hip, Perthes disease, Caisson's disease, or it can be due to indirect factors such as steroids, alcohol abuse, renal transplantation, metabolic causes, or infections such as osteomyelitis or HIV, and in rare instances, pregnancy. So, the common sites for osteonecrosis can be seen in the scaphoid or the distal femur, the talus, capitulum, or even the humerus. And these are the regions wherein the distant part of the bones have vascular territory with precarious supply. And these are largely enclosed by cartilage and have restricted access to the local blood vessels. And thus, they are very susceptible to osteonecrosis and subsequent collapse, which we can see here in all the cases. This is the distal femur avascular necrosis leading to fracture. This is the scaphoid fracture with osteonecrosis features, the talar head and talar neck fracture with subsequent osteonecrosis, and the capitulum also. You can see it is grossly distorted. Also, the humerus. So, coming to the pathophysiology of this disease, it can be due to vascular occlusion, due to direct trauma, stress fractures, sickle cell disease, or venous stasis, or it can be due to intravascular coagulation, or it can be due to primary cell death due to alcohol, steroids, or as in transplant patients. The cellular death of bone components secondary to the interruption of the blood supply, and this leads to the collapse of the bone components. So coming to the blood supply of femoral head. So mainly it has three supplies. So once the blood supply starts from the femoral artery, which subsequently divides into the deep femoral artery, and this further divides into two branches, the medial circumflex and the lateral circumflex arteries. And these form the extracapsular arterial ring. As we can see, the medial circumflex artery crosses over posteriorly, whereas the lateral circumflex artery crosses anteriorly. And it is said medial circumflex artery is the major blood supply to the femoral head. These arterial cascade forms the retinacular chain. These are also known as the ascending cervical branches of the extracapsular ring. Following this, there is a minor arterial supply in the head formed by the subsynovial intraarticular uh, arterial ring, and with a minor contribution from the foveolar artery in the artery of ligamentum teres. So the non-traumatic osteonecrosis can be due to the cascade following arterial occlusion due to any causes such as sickle cell disease, dysparic ischemia, thrombocytopenia, or even fat embolism, causing marrow edema, sinusoidal compression, and vascular stasis, further leading to arterial occlusion. These causes can also be starting from the sinusoidal compression by causes such as the Gaucher's disease, tuberculosis, alcohol, or even dysparic ischemia. The traumatic osteonecrosis can be caused due to the fractures or dislocation, and it can be due to the tear in the retinacular vessels and due to fracture dislocations of the femoral neck. The bone acts as a closed compartment. As we can see here, it is formed by various vascular sinusoids and there is no adventitial layer. The patency and volume of the marrow tissue is confined, and this forms an encasement for these vessels. And one element, as it expands, be it artery, it will further lead to the compression of the vein, and thus this leads to the intraosseous pressure increase. The pathology, as we can see, compared to the normal bone structure, the prolonged anoxia leads to osteocyte death and gross appearance of the bone, although it remains unaltered, the microscopic appearance have striking changes. These can be loss of fat cell outlines, inflammatory cell infiltration, marrow edema, or replacement of necrotic marrow in the mesenchymal tissue. How will we have the clinical presentation of such patients? So here we can see one of the earliest stage is the bone death, and it is usually asymptomatic. The patients usually present with pain, and lesions are seen well in advance. And these, mind you, are the early changes, and they present with just mere groin pain. And the limb will be antalgic, and few click can be seen as a patient complaint. Here we can see the patient has antalgic gait, mainly affecting her left limb, with reduced stance phase and increased stride phase. This is the stage of advanced arthritis, where we can see the joint become stiff and deformed, and the local tenderness will be grossly seen, and the movements of hip are highly restricted, and in more advanced cases, it can lead to fixed deformities and shortening, and rarely you can see effusion in the joints. So how do we approach these cases? The primary goal of the treatment should be early diagnosis of avascular necrosis of femoral head and joint preservation. And the goal should be oriented towards non-operative measures or even in case joint preserving surgeries. But if a patient reaches us in well advanced cases with deformed head or deformities and stiff gait, then nothing but joint replacement has to be done in later stage of the disease. Thank you.